pandemic. So we're going to start in a couple of minutes just to let people, more people to join in. And it's still 8 o'clock in my computer right now. So we're just gonna give a couple of minutes for people to come in. Thank you. It's so good to see the familiar faces on Zoom. Okay, so we're going to get started now since it's 8:02 on my clock. I'm delighted to see that we're joined by a number of attendees, including our distinguished panelists. So before we go ahead and get started, I just wanted to review a couple of housekeeping items. So the first thing is today's talk is being recorded, and the recording will be made available sometime after the talk at CIRA website. So before we go ahead and get started, so the second item is that all the attendees are muted by default, as you can see here. And we will call upon panelists during the discussion so they can unmute their audio and share their comments. And then the third item is we will have a Q&A session towards the end of this discussion. So please type your questions at any point into the chat button here on your Zoom control on this that is shown on the slide at the moment. You may also use the feedback icons to communicate with the host and other participants. So moving on to today's agenda. In a moment, I will introduce our panelists. I will then share with you a very brief poll, and I'd like to invite everyone to respond to the poll. And following that, I will turn the program over to Dr. Luke Davis, who's going to facilitate today's discussion. So introducing our fantastic panelists. In the interest of time, I will briefly introduce our amazing panelists that include the 7 CIRA International Visiting Fellows who are in the first row of pictures shown on the slide. So you can see their faces, names, appointments, institutional affiliations, and also the year when they visited CIRA and Yale as visiting fellows. So to date, since 2016, we've had 4 cohorts of 13 visiting fellows who collaborate with Yale faculty researchers. They represent diverse international settings and countries and multidisciplinary areas of research expertise related to HIV/AIDS. So, and the second row shows the 7 Yale faculty researchers who have participated in the visiting fellow program. So the Yale faculty researchers nominated the visiting fellows, hosted the fellows during their visit, and worked on collaborative HIV research activities throughout the fellowship. To date, we had 11 Yale faculty members from the Yale School of Public Health, Medicine, and Nursing took part in the program. And last but not least, today's discussion will be moderated by Dr. Luke Davis, who took the role as the faculty lead of CIRA International Research Program in the spring last year. And myself, I coordinate the international research activities at CIRA, including the Visiting Fellow Program. So this is my last slide. And as I mentioned earlier, I would like to invite all attendees and panelists to participate in this very brief poll. You can see the 3 questions shown on the slide right now, and I will launch the poll now and give you about a minute to respond before I close the poll and share the results. I have about 60% responded, so that's great. We have 35 people on Zoom right now, so that's fantastic. Thank you so much for taking the time to participate this morning, afternoon, and evening. All right, so I'm gonna share the results. So you are now viewing the poll results. So 14 out of the 25 people who responded are PI, and the rest are investigators, research assistant, and then there's also somebody who's not involved in international HIV rates research. Actually, the first one, the attendees can select more than one option. And so many of the participants have been conducting international HIV/AIDS research between 0 to 5 years and 6 to 10 years. And yeah, and we have quite a number of early career researchers. So thank you. And with that, I'm going to stop sharing and we'll give the floor to Dr. Davis to start the discussion. Luke?
Thank you so much, Denny, and a warm welcome to our International Visiting Fellows and Yale faculty researchers. I know it's a busy time for all of you, and I'll just speak for myself to say it's really a special treat to take a little bit of a break from all the leaders around the world to think about how these challenges and opportunities that are rising with COVID-19 have been impacting you and your HIV research and care delivery, and hopefully get some inspiration and ideas about how we might work together to address these. While I expect that this will be an open and freewheeling discussion and really encourage you to use the tools that Denny went over within Zoom to share your thoughts and questions, and we will have an open area for discussion towards the end, I thought that we might start with the first of the 3 questions that Denny shared and ask about the kinds of challenges that you've been facing. Specifically, how has COVID-19 impacted your HIV/AIDS research activities? Thinking also about the early days of the pandemic up to today. It's ever been changing, and I know that the impacts have sometimes been surprising. A little bit later, hopefully we can discuss and shift to discussing strategies that you may have adopted to deal with these threats in terms of best practices and creative approaches. And I hope that we'll also have a chance to even talk about some unexpected opportunities that have arisen because of the COVID-19 pandemic. And I hope we'll have time to hear from really all the different perspectives around the world. I thought it might be appropriate, though, just to maybe ask Ife if you could just talk a little bit, since you and your colleagues in China have been dealing with COVID longer than anyone, maybe just to get us started, could you just talk a little bit about this question of how COVID-19 has impacted your HIV/AIDS research activities and how that's sort of changed over time, if you don't mind? Oh, Ife, I think you're still on mute.
Thank you for the opportunity. Yeah, yes, we suffered a long time, the longest time. So even till now, we're still suffering from the strict social distancing now. So it's hard for us to conduct the field work research. But we always try to adapt it from the traditional way to the new way. Like we can last month, Dr. Wang and me, we just published one paper. So we used the people, especially the CBO, when they deliver their drugs to the patients, and we can organize some survey among them. But it's hard to conduct some deeper research, especially on the intervention. So because we are suffering from very serious and strict social distancing. Even now, when we go to the shopping mall, no kids are around us, but we still asked to no social activities and not allowed to enter the neighborhood, other people's neighborhood, or even you have to wear masks everywhere. And even when since the coming September, the college is opening, it reopen, but we have to wear masks, and all we have to do the nucleic acid testing. So here, can you imagine that it's hard for us to do some kind of real serious field work? So that's the biggest challenge. And you know, at currently, the Chinese government are quite control a lot of things that seems there's no much words or no much space for the professionals to provide the technical advice. Seems everything comes from the bureaucrats. So can you imagine that? So it's hard for us to get our hands in to change the situation, to provide more. Although we are involved to their kinds of political development and to the different guidelines from the ministry level and to the city level. But the things that they still think the reopen is kind of political risk, so they're not accept this. So it's hard. Even all these kind of the routine, the HIV intervention and the testing is all just like a kind of stopped. That's stopped.
Yeah,
that's the story here.
That's really interesting. I mean, I think that, you know, with me, some of the colleagues that I work in Africa and to some degree colleagues working here in the US, that it's been very difficult to estimate the risk. And I think that a lot of things were just stopped kind of cold at the beginning of the epidemic, and a lot of decisions sort of made, not necessarily including the perspective of infectious diseases epidemiologists. Certainly, we had a lot of great modeling, but I think it took a little bit of time in some of the areas where I've been working to look to people, say within the HIV community, that may have things to contribute. I don't know if that resonates with people who are working in other parts of the world. What kind of challenges and impacts have people had in terms of HIV/AIDS research activities kind of during the course of the pandemic?
Yeah,
Luke, I wonder.
Rena, I wonder if you could maybe speak to a little bit to how some things may have been happening in Tanzania and in Africa in general, how the response has been, just given the scale of the HIV/AIDS research and care delivery enterprise in Tanzania and elsewhere on the continent.
Yeah, thank you. For me, being working in a HIV/AIDS care and treatment program with some of the research activities embedded, when COVID-19 reached Tanzania, the national message was transmitted, and we have the National Research Ethics Committee. So that it also came up with a guideline that we are not allowed to conduct any research that involves meeting with people, taking data, collecting data from people. So all that was stopped. All the universities were closed. So if we can find, even the labs were closed. And so initially, it was kind of, what do we do? You know, you are not prepared because it came very suddenly, and it was very challenging because you have some activities going on in some care and treatment clinics across the 6 regions, for example, for me, which I was working on. So our main issue was to make sure the clients are going to the are receiving their treatment, maybe by not going to the facility, but how do we convey that information quickly that please stay at home, we are making arrangements for you to collect your medication. So initially it was very, very difficult. There was a state of panic. Everything went into a standstill, but with time, quickly we started coming up with ways to address, to continue at a distance through virtual interventions. So initially it was tough because of the guideline or the policy that was released by the National Research Ethics Committee for Tanzania.
Marina, could you say a little bit more about what is happening in terms of care in the face of COVID? Like you said, arrangements were being made, but actually how are people getting their medications, and how are their viral loads being monitored, and how are, when people have clinical issues, are the clinics open at this point, and how are healthcare providers staying safe and so forth? Even beyond research, I'm just wondering about the continuity of care in the face of all of this.
So initially, it was directed that HIV AIDS patients who really have the need to go to the facility, they were going to the facility with all preventions in place. For example, they should not enter a facility without a mask. So all our clients were wearing masks, and our staff were wearing masks. But for all other clients who have no need to go on a monthly basis to the facility, so we moved into the multi-month dispensing. So we have a 6 months dispensing for stable patients and also 3 months dispensing. So we encouraged a lot of our patients through messaging, because we usually we have telephone numbers of many of our clients, but we have community health workers who are working in villages. So all these messages were transmitted very fast, that when your medication you're out of medication, you just go for a pickup and you will be given an extended prescription for 3 or 6 months. So care continued for those who were in need to go, but also care continued for those who were in no need through 3 and 6 months prescription. So for the viral load, it was almost the same. That for those who were to have their viral load taken, they will just quickly go with all preventive measures taken just for their viral load, because they know that my turn for viral load will be X date. So they just go there quickly, they take their viral load and go out. In terms of collection of the samples, because we have a hospital, I mean the small dispensaries that were collecting the samples, that transportation of samples continued. It did not stop. Yeah. So in a way, service delivery continued with a modified way. Yeah.
Do you have any sense that HIV patients are at higher risk of getting COVID or dying more quickly or experiencing more adverse events than the general population? I saw a presentation yesterday that suggested that the answer to that question in the US, at least in the VA administration, is no.
No.
You agree? Yeah, that seems to be what people are saying.
Yeah, I entirely agree, because sincerely speaking, we didn't have any reports of our patients. We have quite a big, more than 100,000 of patients currently on treatment, but we didn't have any of the patients really who had a prone to suffering from COVID. So I think
you're saying zero out of your several 100,000, zero as far as you know.
Yeah.
That's fantastic. Congratulations.
Yeah. Yeah, but it's an area for research, I think, when we discuss for opportunities for research. We can check on that because that was against our expectations. But we think maybe the immunity was high.
Yeah,
and,
maybe they're getting higher immunity.
The treatment itself maybe was protective. We don't know, but it was really surprising.
Yeah. I mean, just for people at Yale, Amy Justice presented very similar results yesterday from an extensive analysis, you know, with multivariate control for everything, and found the same thing.
Here, I can share some information from China, especially from the early epicenter of Wuhan. And we have some co-infections. According to the national, because I recently, since I published my rapid communication with the GIS, then they invite me to review a paper that reported an official data from the Wuhan CDC, Center for Disease Control and Prevention. And we reported that in our paper, we reported that we recruit 12 cases of the co-infections. 2 died, 2 cases died. And all of both of them are over 50 years old. But for another research, the data from the notifiable infectious disease, they matched that the record, they identified the 35 cases for from the whole Wuhan city. And as you know that in Wuhan city, the total number is around 5,000 or something, 5,000 cases. No, how much? Maybe yeah, 5,000 something. But the 35 co-infections, and a few. Let me check how many of them died. So we have, but we don't. Both of our papers, we reached agreement that we don't think the people who are treatment, ARV treatment, the COVID-19 increased the mortality risk, than the general populations who only get infected with SARS-CoV-2. This is our the basic ideas. So that's the sorry for interruption. Just for sharing this information. Yeah,
that's extremely interesting. This kind of question. I think it is so challenging with the varying epidemiology and varying availability of testing, really to understand accurately, of course, sort of what the risk factors are. But it certainly seems like HIV doesn't seem to be a major risk factor, or I think this group would be noticing that. I'm just curious how some of those fears might be affecting your patients. And I know many of you are doing clinic-based research, many of you are doing community-based research. What kind of best practices or creative approaches have you adopted to be able to reach out and work remotely? You know, you could talk about how that's impacted your interactions with patients or also with your staff and collaborators. It really is a very rapid change in the way that we interact with each other. And I'm curious about how people have adapted that in different contexts. I know that we talked quite a bit, I think, in some of the previous webinars. I know a number of you are quite active in using social media to interact with your patients, particularly some of the colleagues I know that are working in Asia, where the social media platforms are quite developed for some of the target populations. I'm not sure if anyone could sort of speak about whether that's been an opportunity or how that's influenced your research.
So for example, for Tanzania, we need to understand that our country didn't close. It's one of the countries which did not have a closure for COVID-19. So we continued business almost as usual with a lot of precautions that we should practice all preventive measures for COVID-19. So for a program like mine, we designed a no-go or go policy that staff should assess the situation to the facility if they want to go. And so that was one of the tools which we quickly developed to help the program and our staff to decide whether they will visit a facility or not. But we quickly switched to virtual platforms for monitoring of activities in the facilities. We used WhatsApp. We created every region where we work, there was a WhatsApp group of health facilities representatives, but we conducted Zoom meetings, Teams, phone calls. So quickly we migrated to a virtual kind of communication. So one issue which we did was to improve communication. We had to spend a lot on internet bandwidth for staff as well as for our health facilities, but also we had to upgrade some of the laptops and whatever so that they can accept and they can be able to work on Zooms. Even payment, for example, if we had to pay, we resorted into an electronic mode of payment. So this was very quick because it was like a standstill and we couldn't move forward. So we had to move quickly to a virtual operations.
I'd love to hear a little bit maybe from some of the colleagues in Southeast Asia. How has the epidemic been in Malaysia and Thailand? How have you been impacted in your work?
Well, if I could, hi, I'm Iskandar here. I'm an infectious disease physician, largely hospital-based. And probably I can just mention a bit about Malaysia. Malaysia doesn't often get very much coverage globally, which is unfortunate, especially given the fact that it's done pretty well considering. We've had about 9,000 cases so far since the beginning of the epidemic. And it's down to about maybe 2 digits on a daily basis, very much controlled at the moment, with very, very little community transmission. So maybe just if I could speak a bit from a hospital perspective, because when we unlike Tanzania, we went into lockdown in March, and it was a fairly rapid lockdown after it was initially announced. And of course, with that brought a lot of changes. Now, in terms of, there were 2 services. I mean, if you want to talk about disruption of services, there were inpatient clinical services, outpatient clinical services, and research services. Now, I'll probably mention what is more relevant here, and that is outpatient clinical services and research services. So with respect to outpatient clinical services, we were instructed by the management to defer all clinic visits from 2 weeks of the initial announcement for a period of 3 months, without any backup for telehealth or suggestions of telehealth at that time. We initially tried to do a bit of, and it was largely dependent on the initial units of contacting individual patients and giving the option of conducting outpatient visits over the phone. But management just went straight into sort of overgear. So a lot of it was overreactive rather than underreactive. But I think that was partly probably better. I think it's always good to overreact rather than underreact. But very little preparations were made for patients otherwise. From a research perspective, and if I could just talk about that. So, and more from participating in a multi-center clinical trial, which in itself had a lot of challenges. It's a D2EFT study. It's a second-line study evaluating a new ARV regimen, 3 different regimens for resource-limited settings in collaboration with Kirby. So I think a good protocol steering committee who was dedicated and met very often to revise the protocol, that was essential. I think an overreactive rather than underreactive approach. I think it's important also to understand that during that time, a lot of infectious disease physicians were deployed to COVID. I guess I was fortunate or unfortunate enough to volunteer that I would look after all the non-COVID related issues. And I think that's very important because everybody else went COVID crazy, both in research and clinical areas. And understandably so, there was a huge need and demand for that. But it's also important to gain perspective and say, you know, the rest of the service needs to be covered, even though while services are deferred. So some of the approaches that we took was we looked at study visits on the protocol and see if they were necessary. And so, for example, a 3-month visit, whether that was really necessary. And I think in agreement, we removed that study visit and extended study visits. We provided drugs for a longer period of time, right, from 3 months to about 6 months. And offered patients to defer clinic visits to either over the phone or telehealth. And for that period of time, it worked. Now, 3 to 4 months on, from our perspective, things have sort of, you know, the lockdown was incredibly successful. You know, in Southeast Asia, we're very, very, I think we were told to do things, we're generally very obedient. And mask wearing was very good, and social distancing at the time also was very good. But a lot of things have returned very much to the norm, but with SOPs in place in terms of mask wearing and social distancing. But for us, it really has gone back almost to what it was pre-COVID, with SOPs in place. So research activities never were suspended from our perspective in UMMC, but patients were given the option of not to come in person, and things have slowly getting back to normal.
Oh, thanks, Iskander.
I think Thomas raised his hand. Sorry, Luke. Just want to give an opportunity for Thomas to respond.
Yeah, Thomas, how are things in Thailand?
Hi. You know, in terms of COVID, I think the country's been handling pretty well. We're at day 85 of not having in-country transmission, and the country went into lockdown really quickly, and curfew was enacted, and so things were pretty good. So I think it was tough for, I think, around April. I think April was probably the toughest month. And so a lot of our young MSM that we collected data from, that we're still keeping contact with, have told us that you know, they're not able to access their antiretroviral meds. And however, I think around May and June, the hospitals and the clinics got smart, and they started mailing the meds to their homes. And so that worked out for people who are in Bangkok and in the big cities. But then, you know, what happens with COVID is that during the lockdown, you're not allowed to move across, you know, from Bangkok to other provinces and vice versa. And so some people decided to just go back home to the provinces, people in Bangkok. And then that becomes a problem because the hospital where they're getting their meds are in Bangkok. And so they just completely go without meds then. So the local hospitals then say, well, if you pay now, you can pay us cash at the provincial hospitals, but then you know, the national health insurance will pay you back, which sounds reasonable and pretty easy, but in reality, a lot of people can't afford that. So so that was that's sort of the problem that we're seeing. I was able to, in terms of adaptation, I was able to get some university funding to supplement the young MSM HIV positive cohort that I've had. And I think it was the project I presented when I was at CIRA at the end of last year, to continue the cohort for 1 more year, especially in the times of COVID, to collect data, to really understand what's going on with accessing meds, adherence issues, and even other barriers that young MSM might face. These are positive young MSM. And so the data is being collected now. And I think in And we're doing this every 3 months. So hopefully we have some good longitudinal data to report in soon.
It just really strikes me with this group that's gathered that in the countries that are represented, probably many of the response measures maybe were more dramatic than the actual number of cases. And I just wonder if people could speak to whether there have been any silver linings in terms of unexpected opportunities, or how you think the experience that has come out of this in terms of some of the things that have been described in terms of remote distribution of medications or differentiated service delivery. How do you think that's going to impact research and care going forward? And especially would love to hear interesting stories or unexpected opportunities that people have been able to take advantage of to do more in this area.
If no one else is going to speak, I might talk a little bit about some of the unintended positive consequences, although we could also talk about the negative ones. We have, I know Iskander mentioned that things were, as status quo in Malaysia, but actually the prisons area was one area where research was stopped for some period of time. But in Ukraine, similarly, our implementation research in the prisons was pretty much sort of shut down, and we focused on sort of training and coping measures with staff. But a place where we did see, I think, some move that can be lessons learned from the COVID experience is in our work on implementing and scaling up opioid agonist therapies for people who inject drugs. And this is a countrywide sort of experience. And one of the things that I think happened was that the bandwidth of the internet became a very real thing for communication between providers and patients. And one of the things that sort of emerged with the idea of sort of reducing the restrictions on, taking medication, which was essentially people take it every day, is that they opened up the barriers so that clinicians could decide on a per case basis whether folks could have up to 10 days of take-home medication. And there were a lot of, we assessed this, and there was a huge amount of anxiety both by patients and providers in doing this, and in a number of different ways. There were fears on the parts of patients with regard to the anxiety of physically having to come into crowded settings in order to get their medications. And, unlike HIV with an opioid addiction treatment, even in the US, I mean, the maximum that people can get for take-homes is 1 month. It's not like, 90 days or, 180 days that you can give for an HIV therapy just because of government regulations. But just opening up the dosing to every 10 days sort of reduced the number of clinical encounters, if you were to amortize it over a year, to about 3 million clinical encounters for the 16,000 patients on opioid agonist therapy. And what it did was it opened up a lot of time for the clinicians to be able to devote other time. And one of the things that we learned early on was that there were stressors not only for patients and providers, but it allowed them to begin to think about ways to sort of address what I would call more trauma-informed care, which they were doing routinely since they were not interacting with them on a day-by-day basis. But to be able to do that using telehealth, the health provided through videos is not really strong enough within the communities within Ukraine. But they were able to pick up the phone and sort of inquire about patients and the ones that they were concerned about. So I think it created a differentiated model of care. One of the things that people do worry about is, are we going to go back to the same old thing? We've actually been monitoring for overdose and death, which was some of the concerns by providers. There's been no signal with regard to any of that. People have been relieved to not have to come in each day, and providers have been sort of relieved to not have to have encounters with 200 or 300 people per day, as they're coming in with the clinics. And so I would say that the opportunity has been extraordinary in that people have been able to differentiate the way that they deliver care. They've moved more towards a mobile health or a telehealth, if you will, sort of model to sort of calm and take care of patients who might need some extra services. and it's reduced their sort of in-clinic workload so that they can actually sort of reinvigorate their other activities, which was really important. And I will say that the other thing that has been sort of a learning point is we have done a fair amount of our implementation facilitation in the past, through, phone calls. And one of the things that has happened is that these providers in these settings have quickly moved towards the computer like we're doing now. And so some of the learning things have been done in person. We can share screens, we can do video conferences. And I have to tell you, just bringing them up to date with real science and evidence when they feel as though they're not getting the information that they need has been, very helpful. But it's also allowed us to continue to conduct some research. And, emblematic of this is what Deanie just did at the very beginning. We can do assessments and we can record them, and we can analyze the data from these calls, who's doing what. We can do nominal group technique. We can deploy research methods that we had previously not done before because we had different means of doing that, but it's really sort of transformed the way that we can actually do research. So I would say that I could list all of the negatives and stuff like that, but there have been some positives, not only with regard to research, but even with our implementation. We've scaled up even more quickly and made it easier for clinicians to sort of change their service delivery so that they could do that. So in some ways, COVID has helped HIV prevention. We've got a lot more patients on treatment, and they're much happier with the way that they're getting it, and they're afraid of going back to that. And it's also sort of improved the infrastructure and the way that people communicate.
Yeah, thanks, Rick. Those are a number of really, I think, nice opportunities they've been able to take advantage of and interesting insights. I don't know if others have different ones, or, also I think that definitely in the US, there's been a lot of reporting about the vulnerabilities and sort of the unseen disparities that COVID has kind of laid bare. And I imagine that there might also be some insights, the social isolation of our patients, or other just forms of inequities that have been exposed. I don't know if anybody has any good examples that they've been able to sort of draw more attention to or potentially try to address.
Hi, look, it's Lisa McDade here in Australia. Reflect a little bit in relation to that, to some research that I'm involved in that's actually going on in Scotland, where I'm still involved in various projects. I was based there in Glasgow when I visited at CIRA on my fellowship back in 2017, I think a few years ago now. And when I visited CIRA, my research and my focus on HIV was kind of taking a slight shift towards more of a kind of introduction of understanding mental health, and particularly the kind of connections between HIV and mental health with some of the communities that we were working with within the Scottish context. So one of the things that we've been focusing on recently is about the potential consequences of the experience of COVID and the lockdown in particular on the mental health of the communities they were working with. So primarily young LGBT people within Scotland and also within Australia. And, real kind of concern around the mental health impacts of being isolated from their peers, from their support networks, what that might mean for them. Thinking as well about young people who may still be coming to terms with their sense of identity and may find themselves in situations where they have no support, and possibly within family situations where they're not accepted, and real concerns about the impact of that on them. And then also thinking about the benefits, and I think this relates to some of the things Rick was saying there about the kind of, the digital media that we can use to stay connected, and how organisations have really very quickly adapted how they deliver services so that they've continued to engage with the young people that they had been working with in face-to-face situations, and now delivering those through digital media as well. So really conscious that there are lots of potential unintended consequences that are negative, but there's some positives there as well in terms of how services have quite quickly adapted, and trying to engage with those to understand what the impact that has on the young people who are working with them.
Thank you, Lisa. That's really helpful. We're an international group of researchers, and I think many of us are fortunate to see each other often at conferences and for those involved in collaborations to visit each other on site. And I know that that also often leads to kind of new ideas and productivity. And obviously that hasn't been possible this year and may not be possible for some period of time. And I just wonder what people have found about that, how they've managed to work around that. What do they think some of the consequences or potentially benefits are of that?
Maybe I can add something about that with regards to training and attending conferences. I think there's been lots of positive to that, and I find that I'm more than ever engaging in different webinars, and which otherwise I wouldn't probably have the opportunity to attend. And there's so many now that are free that you know, you don't have to travel in order to attend these. And I'm actually finding lots of benefits with regards to attending different types of trainings, which I otherwise may not have had the opportunity to. I just wanted to add one other aspect with regards to research. So the other thing that I do apart from clinical research is run a lab, and with regards to how COVID has impacted that. So while a lot of clinical studies went ahead in Malaysia, there was this instruction that all labs that are not doing any COVID-related research had to stop. So that did actually impact the progress of some of the work that I was doing, particularly when there's collaborations with different labs all over the world. There are some projects where I collaborate with Singapore, with Hong Kong, with Australia, and each of us do a little part of the particular project. And as a global research group, at different times, people had to shut down their labs. And so that really had put a dent in terms of how we could progress, because we just couldn't work together as we otherwise would have. So there, in terms of lab-based research, I think there's probably been greater impact, particularly when you're working with different labs all over the world, because labs shut down with different waves of the pandemic, and it doesn't all happen together. But I guess different funding groups have manage that differently. Some of the funders that we work with have been pretty flexible with regards to the timeline, and some may not. And some have said that, you know, with regards to we may not be able to cover salaries for the periods that, you know, there's no work going on. So there's been quite a bit of adjustments that we've had to go through. But I guess on the whole, you know, these are things that you just have to work around and do the best you can.
Well, thanks. We are getting towards the end of the session, and I think it might be nice to just open up the floor to some general questions. And I think maybe, Dinny, I'll ask you to help me keep an eye on the chat, so we have two eyes. But I do see one question from Kaveh, which is, how has COVID affected HIV testing rates? Could we hear some comments from the group that are working in HIV testing? I know, Marina, you had talked a lot about that when you were here, some innovative strategies that you guys were doing, and how that was a sort of major PEPFAR target. How has that affected HIV testing in Tanzania?
So because of the initial, everybody was scared. So we have a drop. For example, in my program, we have a very slight, which is insignificant drop of testing services, especially for those clients who were coming to the facilities. And even community testing was not so much done because of the risk. So we suffered a slight drop, but it does, if you put it in a quarter, it is negligible. And I don't know, it's because Tanzania didn't shut down completely. That's why evidence is available. But for us, literally, as I said, we didn't shut down the country. So some of the effects may be very slight and insignificant.
In China, yeah, so far it seems not affect the
I'll move to a question from Fernando. Oh, Ife, I think you broke a little bit, at least from where I'm standing. I think you were starting to say something about HIV testing.
Yeah. Generally, yeah, can I proceed?
Yes, please.
Okay. So in China, it seems not affected too much, but frankly speaking, the reduction of the HIV testing rate is mainly due to the less of the demand, because the people during the social distancing, they become less sexually active, especially among the men who have sex with men. So but in China, we have the very good shipment services, which means that people always can get from the internet to do the testing kit from the internet to very, very cheap. Even from the NGO, that's free, just paid for the shipment. This is the thing. And I want to also to address the Kavi's question that for the web-based recruitment of people who use drugs, or even to do the conduct research with people living with HIV. Yes, we have some experience that with the facilitation of the local CBO, we can use the WeChat, the Chinese social media, like this kind, and also some APP, especially the physician-themed APP, can organize some recruitment for the survey. It really depends on your research questions, so it can do. Definitely we can save a lot of staffing, and also save some very efficient to organize this kind of research, especially during the early stage of the social distancing. People stay at home, and they were willing and to no incentive to attend this kind of survey, to as long as you get entrusted by the some opinion leaders, like for example the MSM and also the CBO's leaders. So that's quite efficient to organize this kind of different kinds of recruitment, because we have different themed APP, and also some social media APP. Very easy for us to.
Yeah, there's a number of questions about social media, which I'd like to come to in a second, but there's also a little bit of chatter while we're talking about testing about the saliva test. I think some people may be familiar that our colleagues, Nate Grubaugh and Ann Wiley in the School of Public Health recently had emergency use approval for a saliva test for not for HIV, but for COVID. Our Dean Sten Vermund is just suggesting that if there's interest, we would be able to organize a webinar to kind of talk a little bit about it. It's an interesting test in that it's not a commercial test. It's a protocol that's meant to be made in a way that people could adopt it really anywhere where they're able to follow the protocol. So if there's interest in that, please just make a note in the chat, and we'll follow up. But there were a couple of questions. I think Fernando was asking, have any of you used social media or tools such as Zoom to reach out and conduct research in people living with HIV? And I know that Shanestelle Brown said that she's doing some work related to recruiting participants through Facebook groups. Other areas that people are using social media in particular in this moment?
So in Africa and South Africa, we're implementing text message support groups. So not exactly the same, but text message support groups. And this is, ongoing work for several years. And they're actually going to start some groups in Zambia for HIV positive pregnant women and new moms. So we're hoping that just being able to reach people remotely is another way of providing care, which we've been doing, but hopefully we can expand that work even more.
Thanks. how that is asking about ethical challenges that has specifically risen out of the COVID-19 pandemic. Certainly stigma, I think, comes up a lot with both COVID and HIV, but are there specific ethical challenges that people have encountered? I could speak to one that's come up in our work in Uganda, is just the availability of PPE. I think initially we had heard that local production had been rapidly ramped up and that there was a wide feeling that there would be enough, but distribution has been a challenge because of the movement restrictions. And we've ended up in a number of scenarios where research staff show up having more PPE than the people that they're working with. So that's one example, I think, of an ethical dilemma that arises, even when you're doing work alongside local implementers.
There is one question.
Oh, yes. I'm sorry, go ahead.
I see a question on how, if one can comment on how they've partnered with NGOs, CBOs, during the disruption in services. For example, for us, we have about 60 NGOs which we are working with. And during this disruption of services, we quickly created a group of WhatsApp group, and we were sending instructions or improvement which they can do, because these are the ones who have the community-based healthcare workers who will reach our clients. So we trained them virtually on how the community health workers should behave amid COVID-19. What should they have? How should they protect themselves? The importance of having a mask as well as sanitizers when they visit the families. And so the NGOs and CBOs really helped us a lot to quickly reach our clients during this era of COVID-19.
Thanks, Marina. I think that is an important question. Thanks to Evelyn for sort of raising that. There's also quite a bit of, I think, good discussion here related to thinking about not just high-tech platforms like Zoom or other analogous forms that require video, but Cindy had some good examples of using kind of lower fidelity approaches such as SMS support groups. And I think Sheila had and Julia had talked about interviews with older adults with HIV, doing those by phone, which I think is also a very important thing, that our rapid move to the digital doesn't exacerbate differences. Donna's just bringing up the question of how, with PEPFAR playing such a role in international HIV care and policy, with Dr. Burks involved in the US COVID response, which has been, I think people are aware, a very large undertaking. How have things changed at PEPFAR? I don't know if any of the PEPFAR partners could talk a little bit about that.
I mean, just to clarify, what I'm asking is, since Dr. Burks has gone off to lead with Dr. Fauci the US COVID response, it seems that she, I guess, I'm not sure if she actually resigned from or took a leave of absence from leading PEPFAR. And I'm wondering, I just looked online, there seems to be a deputy chief, but I've never seen her name in the media or in any article. And I'm wondering who's leading PEPFAR and if there's been changes in PEPFAR policy, formally or informally, since Dr. Burks has been gone. Marina, you must have something to say about this, if nobody else.
Really not so much, but I think what we are missing from the programmatic point of view, the fastness and of issues or directives or guidelines which we were coming from PEPFAR. I think kind of there is a slowdown at PEPFAR, so we also don't know what is going on. But I remember it was like she's going to do the COVID, but still she will manage PEPFAR. So really, I can't comment much, but we are feeling that she's not there, kind of.
Mm-hmm. So you haven't really gotten PEPFAR directed policies and procedures related to COVID and HIV. So everybody.
No, we are getting every week.
Oh.
Every week, yeah, every week there is a guideline from PEPFAR to all implementing partners across the world.
Mm-hmm.
We receive every Friday.
Mm.
Yeah.
You don't know who that's coming from because we don't think it's coming from Dr. Birx.
Of course, it's her team. That's what, because we have webinars every month, and we have every week some new information from PEPFAR on COVID-19 and HIV.
Okay.
So still it's active, maybe, yeah.
Well, I just want to say thank you very much to all the presenters. Unfortunately, we've gone through a very quick hour. I really want to appreciate all the good ideas that were shared. I think we've learned a lot, and hopefully a little bit closer to. We'll look forward to doing, if you'd like to see more content on this type of thing related to COVID or other opportunities that we can take advantage of, please let me or Denny know. And we look forward to staying in touch with all of you. Please stay safe, stay healthy, and we look forward to a better time around the world as we hopefully bring COVID under control. Thanks so much, everyone.
Thank you so much, everyone.
Thank you, and it was a pleasure to meet all of you and see you online.
Yes, yeah, it's so good to see everybody.
Thank you.
Bye.
Yeah, thanks.
Bye.
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 Thank you, Luke.